All right. Well, good morning, everybody. Thank you, Dr. Pappas, Dr. Sufian, for allowing me the opportunity to give this lecture, and welcome to the CVR Fellows. Congratulations on those that are starting and those that are completing. I have the honor of speaking a little bit about the diagnosis and management of post-thrombotic syndrome. And before we get started, for the fellows, this is your code, your QR code for your credit. So please take a moment to scan that if you haven't already. So why is it important to speak about post-thrombotic syndrome? Well, we all know that a lot of time is spent in our training, especially with vascular medicine, in learning about deep venous thrombosis. And why is that important? Because statistically, about 2 million Americans each year are affected by DVTs. And sadly, about a third of these DVTs then progress onto a pulmonary embolism. DVTs combine for approximately 5% of the adult population of annual incidence. And what's really important to understand is that despite us giving our best efforts to treat the deep vein thrombosis, DVTs can occur to up to 10% of patients a year after anticoagulation. Once we think we're out of the woods there, after 8 years after anticoagulation, DVTs can still recur at up to 30% of patients. So anytime a patient has a deep vein thrombosis, obviously getting them the anticoagulation, what have you, whatever you like to do is important. But understand that this is a diagnosis that is not going to go away. And sadly, this still continues to be the most preventable cause of death in the United States of America, despite all the resources. And so, yes, it's very important to maintain our focus on these patients and making sure that, yes, we treat them in the acute situation, but we understand that there may be chronic follow-up that is necessary in these patients. Just as a very high-level review, obviously, we all know the risk factors for deep vein thrombosis. We learned about Virchow's triad in med school. We learned about, trauma, immobility, prothrombotic states. And these are situations where would put our body into a prothrombotic state. So I'm not going to go through that word for word, line for line, but I think all of us kind of have a good routine understanding of this when we're assessing patients in our clinic. Clinical presentation, again, just an overview of what we can potentially see in our clinics. We have a very nice DVT hotline that we have the ability to then serve to our patients in our community. And many of us will have these patients come through our clinics that have chronic swelling. And so not all of the time is this patient going to be diagnosed with an acute DVT. Oftentimes your vascular tech may come to you and say, well, while the patient has a swollen leg, the patient has a clot, but it appears that it's been there for quite some time. It appears chronic. And so the question is, well, what do you do in a situation like that? Or even to add a little bit of more complexity, an acute on chronic, right? So there's situations that may arise where a patient may have had a blood clot years ago and just didn't realize they had it or were never diagnosed with it, but went on to have these long-term symptoms. So of course we will assess the superficial venous insufficiency, but what happens if they don't have that, then what? So again, post-thrombotic syndrome plays a very important role in these type of patients. If you think that DVTs are going to go away, that is false. This is in the hematology journal. It shows that the trends of DVTs, the prevalence is looking to double by the year 2050. And we know that patients are living longer. We know that patients are living with more comorbidities thanks to technology and medicine. And so, unfortunately, DVT rates will continue to be projected to increase. But it's important for us as vascular specialists in the US to remain vigilant of this as we continue to. So let's talk a little bit more about the chronic limb swelling component of this, post-thrombotic or post-phlebitic syndrome. In some textbooks, you may notice that's what it's written as. So I put that here on purpose. So post-thrombotic and post-phlebitic are interchangeable terms. And when a patient has post-thrombotic syndrome, typically there's a couple of reasons why. One, a patient can have chronic venous insufficiency, which we're all very well versed in, but venous obstruction is really, really an important concept that we're learning more and more about as science evolves and Dr. Pappas and his team provide more research. We know that venous obstruction is important to look for in a patient that has chronic swelling. And so we have a very nice vascular package in our labs that allows us to assess, and our vascular techs are educated on this. So please do understand that if you have a patient with chronic swelling and you've ruled out DVT and chronic venous insufficiency has been treated, and despite those measures, patients continue to have chronic limb swelling, you do have another option here, which I'm sure most of us know. Well, common things being common, I just like to always mention that not all chronic limb swelling, as we know, is venous insufficiency. And it's important for us to help educate our peers in the community as they're sending us patients. I find that in my clinic, one of the most common causes of acute limb swelling or even chronic limb swelling that hasn't been figured out is medication side effects, right? We know that there's a lot of medications out there that may have a side effect of swelling. And so while it's a very simple thing to ask, oftentimes if that is the case, it is a very easy fix, and patients obviously are very, very happy. So let's talk a little bit about the venous outflow obstruction or iliofemoral venous thrombosis. We know that out of all the lower extremity DVTs out there, statistically, roughly 25% of symptomatic lower extremity DVTs fall within the iliofemoral system. And within that iliofemoral system, common femoral and iliac veins are certainly involved. We know that as the proximal segments of veins are more involved, the incidence or risk of post-thrombotic syndrome increases, and there's an increased recurrence of venous thrombosis 2.4 times that of distal thrombosis. So again, very important. And you may be asking, well, why does this lead? Why does proximal obstruction lead more to swelling? And, the answer is very simple. It's proximal, right? As the veins are draining more proximally into the pelvic area, there's more of an issue downstream that can occur if there's any type of insult there. Just as a little review of anatomy here, it's important to understand, you may be thinking to yourself, why does proximal thrombosis occur? Why do patients have compression in their pelvic area? If you look here on the left, courtesy of Dr. Frank Nutter, you can see very, very intimate intercommunication between the arteries and the veins in the pelvic system. You can see the inferior vena cava lies anatomically right to the abdominal aorta, and you can then see the branches of the common iliac, external iliac vein intertwined between the internal and external iliac arteries in the pelvic area. But what I want you to also understand is that not all compression occurs in the left side. I think we've all learned a lot about May-Thurner syndrome, and we know that that's left common vein compression by the right common iliac artery. But that is May-Thurner syndrome and May-Thurner syndrome only. There's no such thing as a right-sided May-Thurner syndrome. Compression can occur bilaterally. When that compression occurs, and if you look to the right here, these are all potential modals of compression on the right side. As compression occurs, years and years of trauma can occur at the level of that compression, which can then lead to chronic scarring of the vein, which can lead to clot formation. And again, despite our best measures of trying to alleviate this clot, that scarring that remains behind can still lead to outflow obstruction. Post-thrombotic syndrome can affect up to 47% of patients that have a DVT. And this was something back in 1997 that was reported by Dr. Nicolaitis and his team. Well, also 25 to 33% of these patients that have post-thrombotic syndrome will develop severe symptoms. So it's really important to understand that almost half of patients that have a DVT will potentially develop post-thrombotic syndrome. And once they have it, about a third of them will develop some severe symptoms if it's not caught in time, such as ulcers and skin deterioration. This is very interesting statistically. This was reported by Dr. Khan and their team. 75% of the cost of treating deep vein thrombosis is actually related to post-thrombotic syndrome because of all the potential issues that can occur. And this may represent a permanent disability to patients, as you can imagine, as this progresses. For the fellows, what is the pathophysiology of post-thrombotic syndrome? Very simply, if the clot forms in an acute situation, we know that that clot causes local inflammation to the area. And as the vein is trying to recanalize, valvular reflux can occur. The clot can cause damage to the valves. And once these valves potentially become damaged, they no longer coapt efficiently, therefore leading to reflux, which then potentially can cause venous hypertension, leading to leg edema and all the other issues that can potentially occur with venous insufficiency. But we have to understand that once that clot, that nidus is there, we may be able to anticoagulate it, but in about 47% of cases, if that clot still remains behind or still remnants of it remain behind, that can still lead to outflow obstruction and again, potentially causing patients to have chronic swelling and chronic symptoms. When we speak about post-thrombotic syndrome, it's important to have some type of nomenclature, some type of quantitative measure. So if I see a patient in Maryland and that patient then moves to New Jersey, we all have some way to measure this, and that is the Villalta score. The Villalta score is for patients with post-thrombotic syndrome. And very simply, it looks at two facets. It looks at symptoms and it looks at signs. And symptoms are pain, cramping, heaviness, pruritus, or paresthesis. And this is then graded from 0 to 3, 0 being none, 3 obviously being severe. Then there's 6 more parameters in the signs: edema, induration, hyperpigmentation, venous ectasia, redness, or calf tenderness, which is also given a score of 0 to 3. So with 11 components and a scale of 3, the highest number can be 33 in a Villalta score. So you may say, well, how does that translate clinically? Well, interpretation of the severity of post-thrombotic syndrome, typically if the score is above 14, it's considered a severe case of post-thrombotic syndrome or the presence of a venous ulceration. If that patient has progressed to skin changes and breakdown, well, this is certainly considered a severe case of post-thrombotic syndrome. When it's about 10 to 14, it's considered moderate, and anything less than that is mild to none. But important to know, if you see this on nomenclature of Villalta score, it is important to understand that this is used for post-thrombotic syndrome and scoring. So let's talk a little bit about the evolution of treatment of post-thrombotic syndrome. Again, we're all very well versed in treating DVTs, right? And it's important to understand where that came from. And I think it's important to cite the CAVEN trial. The CAVEN trial was a trial that was the late 2000s, 2009, 2011, and 2016. They looked at their 5-year outcomes. And what they looked at was a randomized open label study of 209 patients that had DVTs above the mid-thigh level. These patients were then stratified for pelvic involvement. And what was looked at was intervention in one arm with catheter controlled thrombolysis, catheter-directed thrombolysis, or CDT, with alteplase, which is the thrombolytic. And the other arm, which was the control arm, was low molecular weight heparin plus warfarin, or oral anticoagulation, right? And so the question was, is catheter-directed thrombolysis with alteplase going to have any further benefit versus just run-of-the-mill, start them on low molecular weight heparin and bridge them over to warfarin? And what was looked at in these patients was the frequency of post-thrombotic syndrome and iliofemoral patency. And again, this was a 5-year follow-up review of this open label trial. And I won't belabor you with the numbers, but what I want us to understand is that after 5 years, what CAVEN found was that patency rates in the veins were similar, whether you use catheter-directed thrombolysis or run-of-the-mill oral anticoagulation with warfarin. But interestingly, what was found was that there was a lower incidence of post-thrombotic syndrome in the catheter-directed thrombolysis group. So what do we make of this data? Well, the ACCP came out with guidelines, updated guidelines in 2016, and they stated and suggested and recommended that in patients that have acute proximal DVT of the leg, that the suggestion is anticoagulation therapy alone over catheter-directed thrombolysis be given. However, there was a caveat, and the caveat is patients who are most likely to benefit from catheter-directed thrombolysis are those that have iliofemoral DVTs, symptoms within 14 days with good functional status, a life expectancy of at least a year, and obviously very important, a low risk of bleeding, because the last thing we want to do is cause harm to these patients. If they have a high risk of bleeding, we certainly do not want to give them thrombolytics. So that was the updated guidelines in 2016. Well, then along came a larger study called the ATTRACT trial, which many of us are, again, very familiar with. And this included over 700 patients in the trial. And this trial then looked at symptomatic proximal DVT patients, and it stratified them in those that had DVTs at the iliofemoral level and those that had DVTs at the femoral popliteal level. And then each group was subdivided into catheter-directed thrombus plus anticoagulation versus anticoagulation alone. And these patients were followed up for 24 months. Villalta scores were followed, SEEP scores, QOL, VCSS, and venous duplex studies. And it was a very, very robust study that looked into these patients. And what was found, very interestingly, or what was concluded in this ATTRACT trial, was that while catheter-directed thrombolysis did not decrease the incidence of post-thrombotic syndrome statistically, it did, however, decrease the severity and frequency of the long-term morbidity or the Villalta score associated with PTS. So in other words, the incidence of PTS was not affected. However, those patients that did get post-thrombotic syndrome had a lower Villalta score, lower severity in the catheter-directed thrombolysis group. So there's some controversy, and people kind of have their take on how this trial was conducted and the outcomes. But for the most part, that's kind of what the outcome was. That, with that being said, again, take every patient individually, and understand that if the patient comes in an acute situation and you have the ability to do thrombolysis, then there's nothing wrong with that as long as there's no contraindications to it. So now the question is, if a patient has post-thrombotic syndrome, okay, what do you do, or how do you diagnose that? And the diagnostic features are, we have a couple of options here. The least invasive is pelvic transcutaneous ultrasound. And while it sounds very simple, it can be a complicated ultrasound. And it's, again, performed by a vascular tech that has specialized training in imaging the iliofemoral system. So it's not just a DVT rule out. This is a test that involves various scanning techniques and imaging. So pelvic transcutaneous ultrasound typically is where we start to visualize the iliac veins and to see if we can get diameters and look for reflux. Now, depending on demographically where we are in the country and how many academic centers are around us and how many skilled radiologists we have in our community, you can order a CT venogram or MR venogram, which again, some of my colleagues in CVR feel very strongly about it, and I respect that. I think that it also depends on where you are, because trying to obtain a CT venogram or MR venogram can be very difficult if radiology groups in the community are not accustomed to it, because these are tests that are not readily ordered. So please keep that in mind when you order this test. Do a little research ahead of time to know that if that local radiology group does have the expertise and the ability to read venograms. The old school, or the old gold standard, was venography, where you would inject dye into the veins, which again is very helpful. However, the new gold standard is intravascular ultrasound, or IVUS. Many of us know what that is. And what that is ultrasound that provides a three-dimensional view of the vein from within. It's an invasive procedure where we actually get access into the vein through a sheath and place the catheter on the inside of the vein over a wire. This allows us to get three-dimensional views, measure the lumen size if you're going to balloon and stent, measure the compression of the lumen, how much percentage compression is there. Also allows us to see if there's any scarring within the vein in real time, allows us to see if there's any webbing or synechia, which is another word for scarring within the vein. This is very helpful and impactful in allowing us to treat these patients, because we know that venography is important, but we also know that venography is a two-dimensional view of a three-dimensional object. So there can be times where you miss post-thrombotic syndrome if you provide venography alone to the patient and don't perform IVUS. This is a very nice slide provided by one of my friends up in the Northeast out of Yale that showed surgically what does post-thrombotic syndrome look like. And like the name suggests, it's scarring within the vein itself. It's webbing, it's strictures that are protruding into the vein that can then lead to scarring, that can lead to thrombosis, that can lead to turbulence of the blood trying to make its way through that lumen. If you look to the right, this is an actual image of post-thrombotic syndrome in real time with IVUS. And you can see the IVUS catheter is that perfect circle in the middle, and the light or the dark areas around it is the lumen of the vessel, but you can also see the jagged edges of the vessel itself. It's not a nice ellipse or oval. There's scarring, there's jagged edges within the vein itself that certainly suggest there may be some scarring or post-thrombotic syndrome. So now that you've diagnosed the patient clinically and you've used your modality of choice to help discern this, what do we do with this information? And, treatment is, again, has come a long ways. And again, I'm sure that Dr. Sufyan and Dr. Pappas can certainly speak for that. But as of recent, there's multiple minimally invasive ways to treat this. Stenting has become the preferred therapeutic alternative in symptomatic patients that have lifestyle limiting features that have failed conservative measures. We know that this can be performed effectively in the outpatient setting because many of us are doing that in our practices with low morbidity and excellent long-term results. There's a lot of wonderful data out there. I'm not going to get into the weeds of it, but the data is very favorable in showing that when patients that have symptomatic post-thrombotic syndrome get stented, they go on to do quite well. I would like to just make a quick note about compression stockings. This is important because compression stockings are drilled into our mind as to how important compression is and how important it is to do conservative measures. And I'm not going to dispel that in any way, but I do want to bring forth a very interesting trial that was conducted called the SOX trial, or the SOX. It was a multi-center randomized placebo-controlled trial of compression stockings that looked to see if after a patient experienced proximal DVTs, did compression actually prevent post-thrombotic syndrome, which is, again, very, very interesting, right? So what they concluded and found was that after this trial was concluded, compression stockings actually did not reduce the incidence of post-thrombotic syndrome or have other important benefits. And it actually found that the use of compression did not reduce leg pain 3 months after the DVT diagnosis either. So symptomatically really didn't make a difference. But more importantly from the study, for the relevance of this talk, compression stockings are not going to reduce the incidence of post-thrombotic syndrome, which was concluded again from this study that I all encourage you to read. This was done by Dr. Khan et al. And with that being said, I'm going to conclude last couple of slides here. I want to talk a little bit about stenting because I've mentioned it a couple of times, and I know that many of you may have had patients in your practice that you've sent to CVM, Center for Vascular Medicine, that have had stenting performed. And so I think you all know that stenting has been around for a long time. CVM didn't invent stenting. That was there many years beforehand, and there's a lot of wonderful trials and studies that have been performed. I'd like to just cite a couple important ones for us to be noticed. In Journal of Vascular Surgery in 2002, Dr. Raju and his team, Dr. Neglin, looked at the clinical impact of iliac vein stents in the management of patients that had venous outflow obstruction. He looked at 304 limbs with iliac vein stents that were, by the way, placed in an outpatient setting. And roughly 280 of these patients were C3 and above. And what they looked at, they found when they looked into these patients was significant improvement over 2 years.
Vinay, you're muted. We can't hear you. Yeah, we lost your audio.
Can you hear me now?
Yeah, we got you.
Okay, sorry about that. How far did I get to? Did you hear the slide?
At this slide, I think at the beginning of this slide here, Vinay.
Oh, sorry. Okay, great. So you guys can hear me okay now?
Yes.
Yeah.
Okay, continuing on, I apologize. So the question here, this was an impactful study that was published in 2002 by the Journal of Vascular Surgery, Dr. Raju and his team. And the question was, does iliac vein stent help? And they looked at 304 limbs with iliac vein stents that were all placed in an outpatient setting. 280 of these patients were C3 and above. And what they found was over a 24-month period was that when patients that had symptoms and failed conservative measures, there was symptomatic improvement if an iliac vein stent was placed in these patients in pain, swelling, stasis dermatitis, and ulcer healing. What they also found was that iliac vein stents were effective when utilized in the correct clinical scenario. Minimal complications were found with high patency rates. Well, roughly 11 years later, looking at over 1,500 patients, the question then again was we looked at and published in Journal of Vascular Surgery by Dr. Raju and his team about what are the best management options for patients that have chronic iliac vein stenosis and occlusion. And these were patients, again, 1,500 patients with disabling symptoms and who failed conservative measures. And I've said that about 3 or 4 times because I think it's really important for us to understand that just because we can stent doesn't mean we should stent. Stenting is usually the last option. And as we all know, same thing with ablations. We're not going to go directly to performing an ablation on a patient without providing those conservative measures and understanding if the symptoms are not disabling or lifestyle limiting, to leave them and keep an eye on them. But once a patient does progress to that, I think we all understand that these patients are then more than good candidates for having a vein stent placed. Morbidity less than 1% they found in that study, with patency rates at 3 years with the non-thrombotic group of 90 to 100%, and the post-thrombotic group 74 to 89% patency. Relief of pain, 86 to 94% of the patients had relief of pain. Relief of swelling, 66 to 89%. And also look at this, venous ulcer healing rates, 58 to 89%. So if you can get a patient to that percentage and get their ulcer healed, and you know that they have venous outflow obstruction, then I think studies like this, and there are multiple studies out there, these are not the only ones, but there are multiple studies that are very favorable in showing that when done in the right patient, the right situation, the right scenario, these patients do quite well. I'd like to end with a case. This is an actual case of ours. This is a 68-year-old female who has a history of recurrent left medial ankle ulceration. She's been dealing with this ulcer for 6 years. And she came to our clinic. She had persistent leg and foot swelling on that side. She had never had any trauma to the area. And she had multiple venous ablations performed. She had a GSV that was refluxing, and it was treated, and it closed. But unfortunately, the ulcer, while it started to improve, and she came back for her follow-up, we found that the GSV was recanalizing or opening back up, and the ulcer was worsening. So I went back and I treated it again, thinking that, hey, maybe the first time wasn't the charm. She was also followed very closely by podiatry and wound care. So I figured, hey, let's see if we can get some wound care involved, and maybe we can, do a little TLC from the outside. Notably, the patient had a past medical history of a left leg DVT 15 years ago, and she was treated with warfarin at that time, and there were no issues, and life moved on, she said. She also has hypertension and anxiety. So here's a situation now, ladies and gentlemen, where you have a patient who has an ulcer in her left ankle, and she has multiple ablations performed. And it was done by me. So I'm not saying I did 13 ablations on her, but I did 2 ablations. And after my second ablation, I'm thinking to myself, is there something else? Am I missing something? And this is one of my earlier cases in my career. And so I like to share this case because this was like the light bulb going off in my mind that, well, why does this vein keep opening up, and why does ulcer not heal? Why does it keep? I understand the connection between the vein, superficial vein, and the ulcer, but I don't understand why the superficial vein isn't closing. And so then, I spoke to, some leaders like Dr. Pappas and Dr. Soufian, and we came up with this idea, let's try a pelvic duplex ultrasound and see what the iliac veins look like. And again, this was very earlier on, and our vascular techs were not as well versed as they are today. But the vascular tech came back and said, listen, there's a lot of bowel gas. I mean, I can't really see, well, although this lady is not that heavy, I just can't see the actual vein itself. It's so hard to penetrate with the ultrasound. And this is, by the way, what the ulcer looked like. Because you can see that there's definitely a deep crater in the left medial ankle gaiter area, very characteristic, red and hyperpigmented, very characteristic of a venous ulcer. So we're very, very confident that this was venous in origin. And so we then moved on to venography. So the iliac vein ultrasound was inconclusive based on those parameters. And so we went to a diagnostic venogram. And when I first looked at this venogram, and for those of you that can see the screen, you see the dye going up the left and right side, meeting at the middle, and going up the inferior vena cava. You can immediately look, when you look at it right away, you said, oh, okay, what's the big deal? I see dye going up the left, and I see dye going up the right. And I said the same thing, and I said, oh, okay, so I think this patient's normal. Well, if you look closely, it's not normal, and I'm going to come back to that. So this is why venography is not the end-all be-all, because again, it's a 2-dimensional view of a 3-dimensional object. So we then went ahead and inserted an IVUS into the left iliac system. Before I do that, I do want you all to note something. Do you note that as the dye is making its way up the left system, there's what you call little collaterals that are being recruited. You don't see the dye going up in one line as you do on the right side. You see the dye trying to find other little channels around, and those collaterals should not be there. That is a telltale suggestion from a venogram that there potentially is some type of venous outflow narrowing or obstruction. And again, that is something I learned afterwards. So here's IVUS. As you can see in real time, you see the IVUS pull back. This is the inferior vena cava, a nice oval. And as we're pulling the IVUS catheter back, you see all of a sudden the lumen is all hugging the catheter itself. And the lumen is jagged. You can see the irregular borders, the finger-like projections coming into the lumen itself. This all signifies chronic scarring. And I got to tell you, this was very eye-opening, because when I looked at the venogram, I said, well, dye's making its way through. How's the dye actually making its way through? It doesn't look that bad. Well, again, because I'm trying to use a two-dimensional modality here, and that can lead to, a misdiagnosis. So this is just, again, very important slide showing how IVUS, or intravascular ultrasound, is essential in helping diagnose a patient that has post-thrombotic syndrome in our practice. Once I was able to nail that diagnosis down, I put an iliac vein stent in the left system, and what you see now is no longer the dye going into collateral branches, a very nice inline flow, inflow and outflow through that stent, making its way into the inferior vena cava. So really important to understand that, again, iliac vein stenting is helpful in these patients. Well, how did the patient do? Look at this. At 3 months, you can see that the ulcer, although it has not closed, it definitely looks like there's some scar tissue that's growing over the ulcer. But look at this at 6 months. At 6 months, we were able to get that ulcer to completely heal. This patient was obviously, needless to say, ecstatic, very, very appreciative. She had gone years and years without understanding why this was happening. And finally, she was able to get the relief and treatment she needed. So this kind of comes to show that, again, it's important for us to put all the pieces of the puzzle together. We're not just vein specialists, we're vascular specialists. And it's important for us to appreciate not just the superficial vein space, but the deep vein itself, and the importance and the interconnection between the two. So in conclusion, endovenous stenting has emerged during the last decade as a method of choice to treat venous outflow obstruction, as I've shown you. Post-thrombotic syndrome should be assessed in patients that have a history of a DVT and chronic swelling. It doesn't matter how many years old that DVT is. If they have persistent chronic swelling or symptoms, please do think about post-thrombotic syndrome. And again, I'll say it again for like the 6th time, stenting of symptomatic venous outflow obstruction of the lower extremity can be performed with low risk, long-term patency rates, and low instant restenosis, but they should have symptoms, and it should be lifestyle limiting. And IVUS, again, hopefully I've shown you, is critical in determining the lesion presence, severity, and the sizing of the stents and balloons. So with that, I'd like to conclude the formal session and open it up to any conversation, any input, any questions. And again, I thank Dr. Pappas and Dr. Soufian for this opportunity.
So thanks, Vinay. I just have a few comments on some things that you mentioned during your talk. So I think one of the important points you made was about meds. I think we're all pretty familiar with the fact that calcium channel blockers and amlodipine are associated with like ankle swelling in particular. But don't forget, I think we all think that the most common side effect of ibuprofen is actually stomach ulcers. It's actually not. It's actually ankle swelling. So we prescribe a lot of ibuprofen for our post-op meds after an ablation. Just remember that ankle swelling is associated with ibuprofen as well. I think you very appropriately discussed the Villalta score. I think we all know that it's an overly sensitive parameter or survey tool. I'm not a big fan of the Villalta score because I think it's way too subjective. And right now, with the after the ATTRACT trial, I think they came to the same conclusions, and they're actually focusing more on RVCSS rather than Villalta score. But you will be seeing Villalta; it's still being used. Just keep it in mind that it's overly sensitive, and I don't think it's a real good predictor of real post-thrombotic syndrome. You mentioned the thrombolysis trials. So one of the things I want to just alert the fellows to, one of the problems with the CABIN trial is that although they did find that the thrombolysis group had a lower incidence of post-thrombotic syndrome, there was a very, very low incidence of stenting in that group. And they left a lot of residual thrombosis left behind because they were not using mechanical thrombectomy devices. So that may have further prevented the improvement in post-thrombotic syndrome because they left a lot of disease behind in that group. And in the ATTRACT trial, Vinny is absolutely correct. It wasn't until Dr. Kamrad did the subgroup analysis where they took out the femoral popliteal patients and they looked at the patients who just had iliac DVTs, and those patients significantly improved even with Villalta score and RVCSS. So clearly, I think the patients with the more severe DVTs are the ones who benefit more from the thrombolysis. And I think even with the new C-track trial, I think they're actually put percutaneous thrombectomy devices there as well as part of the trial to try to eliminate that residual thrombus effect. So I think some of the newer trials, you're going to see more and more percutaneous thrombectomy devices maybe used in conjunction with thrombolysis, not only because of speed, but because they want to eliminate any residual thrombosis. And I think more stenting in this group is probably better than less stenting if you want to minimize the incidence of post-thrombotic syndrome. So those are just some quick comments. Does anybody have any questions for Vinay on this talk?
I have a question. Good morning, this is Priya. Can you guys hear me?
Yeah.
Yes,
go
good
ahead,
morning,
Priya.
Priya.
Hey, good morning. So a couple of questions for this lady. Did you re-ablate her GSV after the stent went in? And I think the answer is yes, but I wanted to hear how long her GSV did not recanalize. How long did it stay after stenting?
Yeah,
Did
yeah,
she
no,
have
thank
GSV
you.
improvement?
Yeah, sure. What was your other question, Priya?
Oh, my other question was, so when I see my pelvic patients, it's no surprise. I love the benefits that the stent gives a patient, if anybody knows how I practice. But I often tell patients with recanalization that I want their stent to go in relatively in a close proximity to either when I reablate them or get the stent first and then I reablate them, meaning like 1 to 3 months. Is there actually data that I can be quoting that will tell me, oh, okay, if you're going to reablate somebody, then, and we don't want it to recanalize for a second time, that doing it within X amount of time from when they get stenting would actually be the best time. You know what I mean?
Sure. No, these are all valid points. So to answer your first question, this patient, after we put the stent in and after the patient had improvement in her ulcer, we followed her GSV reflux. She did have pockets of reflux, but I did not decide to do anything at that point because of the fact that the ulcer had healed and she really didn't have any further symptoms. And again, her reflux was so, it was not proximal to those areas. So I left it alone, but I think these days, if a patient has residual reflux in those areas, we have non-thermal, non-tumescent modalities like Varithena that we could potentially use. This was before that time, so I just didn't have the need to put a thermal catheter in there again. So I left it alone, and she did very good. And again, she was very happy. So we left that be. To answer your second question about is there a time between doing an ablation and doing the iliac vein stent? Dr. Pappas, I'd like to hear your thoughts on this because I think, data-wise, you're the man.
Yeah,
Peter, can I just
give me 1 second. So again, I think the underlying premise to Priya's question is whether or not recanalization is caused by a proximal iliac vein obstruction. And the answer is there's really no data to indicate there's a correlation. Logically, it makes sense, right? If you have proximal venous hypertension and you ablate a vein and it reopens, there probably is some relationship, but no one's actually done an analysis looking at that as a question. So Priya, I don't know the answer to your question. If you really feel that proximal obstruction was a proximate cause of your recanalization, then once you stent that patient, the obstruction's gone, you should be able to ablate your vein whenever you want.
Well, thank you, Peter. I was just going to mention the same thing. In other words, we don't have data to show that when you do the stenting, that it really improves or it has any effect on the recanalization. So that's a good point. But Penny, to supplement your point of your patient that you did not, Dr. Raju has good data that many years ago reported that when they were planning to do the superficial treatment, they did first the stenting, and they were planning to do after the stenting the superficial. Then they found out that the mere stenting alone healed most of the ulcers, and they did not go ahead and do the superficial. And there is data on that.
Exactly. Yeah.
Yeah,
No,
but
well said.
Siki, my recollection was that in that paper they did treat this GSV, because what they did, they treated them both simultaneously. They did the stenting and the ablation, but what they found was that the diameter of the GSV reduced after you relieved the proximal outflow obstruction. So, and remember, they had a large incidence of post-thrombotic patients in their
Yes.
treatment group. So I don't, the non-thrombotics don't behave the same thing as the post-thrombotics. They're obviously much more severe disease associated with it.
Absolutely, absolutely.
Yeah, I think that, when a patient has PTS, if a patient has PTS and we treat the venous outflow obstruction, obviously it's important for us to continue to follow the patient. If they have recurrent symptoms of any sort and they have correlating venous insufficiency in their superficial system, nobody should feel shy to treat it. But I think that if, to answer Priya's question, in a situation where they have pure venous outflow obstruction, you've sent to the patient and they have symptoms that are still persistent, don't feel shy to treat the superficial venous system as long as you've, ruled out other causes.
Yeah, I agree with Vinay on this one. If that patient has a venous ulcer, I say you throw the kitchen sink at them. Because not only do you want to get it healed, you also want to decrease recurrence. You want that ulcer-free recurrence time to be higher. So if there's any residual superficial, reflux left in that patient, I wouldn't feel shy about treating it at all. Any other questions for Dr. Satwah?
Thank you.
Hey, Vinay, I actually have one question. This is Sean.
Hi, Sean.
Can you hear me?
Yes, sir.
Okay. So how do you approach a patient who has a iliofemoral DVT and you have an ultrasound that shows P-throm of their femoral vein, and they also have significant dysphagia? So my dilemma is how to pay on the superficial system, and if you close that, are you going to make things worse? Is there any way we can evaluate the function of the deeper system in these type of cases?
So I'm sorry, a part of it broke out. I just want to make sure I understood the question. So the question is, if a patient has some potential venous outflow obstruction, but they also have a DVT or scarring lower down in the femoral system, should we be shy?
Correct.
Or should we be concerned? Okay, I'm going to give you my thoughts, and obviously I want to hear Dr. Pappas and Dr. Sufyan's thought on it. My thought is, in a situation where somebody has venous outflow obstruction, and even if they have distal narrowing of any sort, in my experience, when you alleviate the venous outflow obstruction, you're improving that venous outflow. So whether they have collaterals distally or how the blood is getting around there, it still will improve the patient's symptoms. You should not be shy to treat them if they have distal DVT. In fact, it's more of a reason to treat the venous outflow obstruction because you're decreasing or improving that watershed effect. Now, with that being said, I have treated, unfortunately, I've had about 4 or 5 situations where I've actually stented the femoral vein, and 5 out of 5 times the stent occluded. And I think what happens is the flow in the femoral vein is so low that trying to treat obstruction in the femoral vein probably, in my opinion, is not going to be putting a stent in. I think in that situation, anticoagulation, compression, and whatever you can do to treat the venous outflow obstruction would be the best for the patient. But your thoughts, Dr. Pappas and Dr. Sufyan?
Vicky, what do you think?
Yeah, Peter, I'll only go back to our old days when we did treat the superficial system by stripping, and there was a big fear of when you strip, if you strip the saphenous vein, there may be a problem. And the question was, in patients with deep venous thrombosis, we didn't have a detailed anatomy of knowledge of the DVT, where they are and so on. But it was not true, and in majority of the people, nothing happened. And this is because the deeper system, the deep femoral, so long as that one is open, you're not going to do anything bad. The only case, I have only one case that I know of that happened in Philadelphia many years ago, that the patient had really a totally occluded system in the deep system, and the saphenous vein was ablated, and the patient ended up losing a leg. And that's the only case I know. And therefore, this relation between the deep and the superficial, in the modern era of stenting, you guys are doing so great in terms of opening it. And I don't think there will be going to be much of a problem.
Yeah, so my feeling is to answer Sean's question, it's all about the profunda femoris, right? If the profunda is open, but your femoral vein is occluded, you're gonna be fine and you can ablate that superficial
exactly-
vein
that's
without any concern. It's when the profunda and the femoral are both out together, that's the group that you probably should be very cautious on.
Careful, exactly.
Great. Thank you.
All right, so if there are no other questions, have a great Memorial Day weekend, everybody, and thank you for joining, and we'll see you next week.
Thank you.